mana? Ni Audi siapa jaga? Kau ke siapa? Minta tolong weh. Audio tak masuk.
Nasopharynx extending from the left side to the right side. This is the right side. So, and also the eustachian tube opening will be here. So you can see slightly polypoidal, and there was a lot of contact bleeding, and it appears friable as well. So then the mass is contiguous from the nasopharynx to the fossa of Rosenmuller. And slightly, we also can see that there is a bulging of the septum, posterior septum, as a result of mass effect from the contralateral nasal cavity. So other physical examination, otoscopic revealed normal ear canal, bilateral tympanic membrane was intact, cone of light was seen on bilateral ears. Neck, there was no neck swelling. So on oral cavity, there was no trismus, was partially edentulous, good oral hygiene. However, we noted there was loosening of upper molar tooth, but there was no discharge or no sinus. Tonsil were grade bilateral 1. There was no medialization of the lateral pharyngeal wall. Laryngoscope 70 degree was unremarkable. Bilateral vocal fold were mobile. On auscultation of the lung was equal air entry. Cranial nerve, there was no gross cranial deficit except maxillary division of left trigeminal nerve, which is a slight reduction in terms of sensation of the left cheek area. So in summary, this is a 63 years old female who presented with left nasal blockage for 1 year duration, which is progressively worsening, associated with blood stain secretion, left cheek swelling and numbness, and left eye swelling for 4 months duration with upper molar tooth loosening. On examination, there was proptosis, left maxillary numbness and swelling. On nasal examination, there was a mass protruding from the left nasal cavity. On rigid endoscopic, see there was a friable polypoidal mass occupying the nasopharynx extending from the contralateral side. So now that we have heard the history and the physical examination, let's look at the possible differential diagnosis with the history. So with the age and the presentation and the constellation of symptoms of both sinonasal and orbital, this points towards first differential diagnosis would be a malignancy. So our provisional diagnosis was a left sinonasal squamous cell carcinoma. Squamous cell carcinoma is the most commonest carcinoma in sinonasal region. So, and clinical staging according to AJCC's 8th edition, it is T4N0M0. The reason is T4 because there was involvement of eye in terms of proptosis and swelling from the patient and reduced visual acuity. Differential diagnosis, a benign cause would be sinonasal inverted papilloma. The other differential diagnosis we would like to entertain is left sinonasal lymphoma. Sinonasal lymphoma is more rare, and also the other differential diagnosis is left nasopharyngeal carcinoma. So now let's look in depth what are the points for and the points against for each provisional and differential diagnosis. So for sinonasal squamous cell carcinoma, again the symptoms is persistent, progressively worsening nasal blockage, and it was a blood stain discharge, and there was a cheek swelling indicating the extension anteriorly from the sinonasal region to maxilla to anteriorly to the cheek swelling and causing the numbness, possibly involvement of the infraorbital nerve, which is situated at the roof of the maxillary sinus or direct extension of the cutaneous nerve. There was an eye involvement, extension of the mass superiorly causing the eye swelling. There was a mild proptosis, there was no chemosis and reduced visual acuity. And this mass was friable and bled to touch. So these are the points that leads to us as a malignancy and likely a squamous cell carcinoma. What are the risks against the points for is there was no risk factor. The patient was a non-smoker, no occupational exposure to dust, wood dust or fume, and usually sinonasal CAs are more common in male when these are the points against. So the second is more benign cause of sinonasal inverted papilloma. It presents similarly with unilateral nasal blockage. The age 5th to 6th decade is also a common presentation. Again, it can have a blood stain, nasal discharge or epistaxis. The factor against is no risk factor and there was eye involvement. I would like to put a disclaimer, even though some inverted nasal papillomas can erode the lamina papyracea and involve the eye as well. But if there is involvement of eye, then we think about more to a synchronous squamous cell carcinoma or malignant transformation of a sinonasal inverted papilloma. So the other third differential diagnosis was a sinonasal lymphoma. Again, the constellation of symptoms located in the nasal cavity can still present similarly with lymphoma. Particularly more common is diffuse large B-cell lymphomas. Non-Hodgkin lymphomas are more common. The second most commonest being the NK T cells, natural killer T cells carcinomas. But what are the features against is usually lymphomas tend to present with neck swelling as well, even though we know that any sinonasal malignancies, the propensity of having neck swelling is low compared to the other head and neck malignancy regions. And often we also have erosion of hard palate or non-healing ulcers over the hard palate as a result of erosion of the floor of the nasal cavity or the maxillary sinus. It points against the lymphoma, and there was no systemic manifestation. Finally, being in Malaysia, in Southeast Asia, is an endemic region for sinonasal carcinoma, nasopharyngeal carcinoma. So, not forgetting, the symptoms can be still persistent nasal blockage, blood-stained nasal discharge, and eye involvement. Sorry, I didn't put the ear involvement as well. Patient also had tinnitus. Also can be nasopharyngeal carcinoma. But what are the points against? Most commonly, nasopharyngeal carcinomas presents with neck swelling, huge neck swellings, and there was numbness of cheek. It is very unusual for a nasopharyngeal carcinoma to have numbness of the cheek. Being most commonest nerve involvement in NPC, nasopharyngeal carcinoma, short form is NPC, is 6-nerve palsy as a result of involvement of Dorello's canal. Or the superior extension to the cavernous sinus can produce with cranial nerve 3 and so on, but not so much of numbness of the cheek. The other thing is the mass extending to the nasal cavity and protruding out. It is also unusual for the nasopharyngeal carcinoma to come anteriorly. It usually goes superiorly, finds the bony erosion, but it's not uncommon. The other one is similar to the numbness of cheek. There's no other cranial nerve involvement. So with these differential diagnosis in our mind, then let's go to our proposed investigation before we release. So my proposed investigation would be a transnasal office-based biopsy in a clinic, and then moving on with imaging, contrast-enhanced computed tomography of paranasal sinuses, and as the patient had blood-stained discharge for about 4 months, we would also like to take basic investigations such as full blood count to look at the hemoglobin level, electrolytes, looking at the for comorbidities, and also chest X-ray as a pre-op investigation. So with that in mind, I would like to pass on to our next presenter, will be Dr. Aida. Right.
Okay, thank you, Dr. Iliyas, for that wonderful presentation. Sorry, I'm sitting at the back here because I don't want to go up the stairs, up and down. Iliyas, did you order imaging first, Iliyas? Out of the 3?
For this patient, we did office-based biopsy first. Then we ordered imaging.
Already biopsied. Okay, so we would like to welcome Dr. Aida-Widure Mustafa to present the radiological findings of this patient. Okay, so while we are waiting for Dr. Aida to set up, we can take a few questions for Dr. Iliyas.
Thank you. This part of the teaching session, if you look at the history and examination, Iliyas, for me, I don't think inverted papilloma will be second. And because this is a typical, if you go for a long case, this is a typical case that we're going to give to you. So I think, for me, I think I will put maxillary CA first. Why? Because you look at you punya history, it's all typical of maxillary CA, and especially if you have loosening of the tooth. Kan? So as sinonasal, NPC especially, all these sebenarnya is tak bagi, doesn't present with a typical symptom of loosening of the teeth. If that is significant, I would put maxillary CA first, and I would put the inverted papilloma belakang lah. Betul eh? So I mean, maybe you are biased on, you know about the before that, but I think we still have to in our mind of thinking of maxillary CA, because it is typical of maxillary CA punya presentation. So you still, when you come to a provisional diagnosis and differential diagnosis, think about the history and examination. Kan? So and I would agree, I definitely agree, NPC probably belakang because like the neck notes kan, such a big mess. Tapi Madam Chairperson, I would still think, because I'm sitting next to Maxis oral and maxillofacial professor sebelah, dia pun kata yes, CA probably something you need to think of. Okay, thank you. And inverted papilloma doesn't give this kind of features of malignancy. Okay.
Thank you, Prof. Razif, for that comment. Yeah, I think for the medical students' sake also, this presentation is typical of a maxillary sinus CE because of the cheek swelling, loosening of the tooth, and a mass protruding out of the nose. And it's an elderly lady. I agree that NPC would be lower down because NPC generally presents with neck nodes if they have large tumors. I'm just wondering why sinonasal undifferentiated carcinomas, other sinonasal cavity tumors did not come into your differentials. Do you want to answer that, Iliyas?
So the first provision diagnosis actually I put as a sinonasal malignancy. Under it, I didn't classify as a histology section. So under sinonasal malignancy, I would put most common is squamous cell carcinoma, undifferentiated carcinomas, and neuroendocrine tumor. So I classify it that way. So I cover the malignancy part as the first provisional.
I see. Okay, then for the postgraduate students during exam, we expect you to give a specific pathologies. Squamous cell carcinoma, which sinus? Maxillary. Okay, then my differentials can be sinonasal undifferentiated carcinoma. Most common sinus is actually ethmoid, but can occur in the maxilla. Okay, thank you. So Dr. Aida is ready. We can move on to the next presentation.
Okay, thank you, Miss Moderator. So I will start my presentation. I'm Dr. Aida from the Radiology Department. So these are the contrast-enhanced CT brain and neck of the patient. So I give you the soft tissue window in the left and the bone window on the right. So straight away we are seeing the enhancing mass, large in the left nasal cavity here. And it extends anteriorly to the nostril, the left nostril, and then it extends posteriorly to the nasopharynx. Okay, so if you can see on the bone window, there is a residual nasal septum, which is mostly eroded and bowed to the right side. Okay, but it is partly dehiscence and bowed. So the right nasal cavity is very narrowed and predominantly compressed by this mass. On the bone window, we see the maxillary wall is dehiscence, eroded, and possibly even the destruction, as shown in my yellow arrow. Okay, and if you look at, you can compare left to right. So comparing to the right side, there is already destruction of the medial pterygoid plate here. Okay, and you also see part of the enhancing tumor beyond the lateral pterygoid plate here. And in the same axial plane, we have a left retropharyngeal node or pre-styloid node, which shows hypodense center. So this is an enlarged node with necrosis. Okay. If you look carefully at the lateral wall here, there is a defect and like a tract extending into the. Oh, I see. Sorry. Laser. Mana? Oh, I'm sorry. Okay, so if you look carefully here, this is the left maxillary sinus. It is filled with fluid, and it is most likely due to obstruction from where it's supposed to drain, and it's producing some sort of like a mucocele. And there is a defect here in the left lateral wall of the maxillary sinus. Okay, so if we were to go above, axial above, we see this hypodense lesion or possibly mass with peripheral enhancement, and it causes swelling of the left cheek. Okay, and when we I were to scroll the images, which I don't have here, there is a track communicating this to the small opening that I showed you earlier. So this is likely like a left maxillary kind of mucocele which has infected, and it has produced a tract to form a collection over the left cheek area. So I think probably that's why the patient has tenderness. And on the same axial setting, we have an enhancing node. It is about 1 point something in long axis, which have central necrosis. This is a left 2B node. Okay, and this is partly, we can see partly another enhancing node in the left 2B as well. Again, if we were to go up, most of the pterygoid bones is also destroyed here. Okay. So this is lower down. Oh, sorry, we're going back down again just to show you that the left 2B node has also necrotic component within it, and it is enhancing. Okay. So this is the area of the oral cavity which appears clear. All right. So this is the lower border of the left maxillary sinus, and the bone surrounding the root canals of the teeth appears intact. Yeah. So now we are moving on to the brain part. Just at the upper eye level in axial plane, there is a enhancing soft tissue in the left medial cranial fossa. This can be in the cavernous sinus, and if it is, then it is also abnormal. So this tells us that likely that the left cavernous sinus is involved, because usually the left cavernous sinus has a concave configuration, but this one is bulging outwards laterally. And in the same axial cut, we see that there is a prominent left superior orbital vein. So this if you compare to the right side, so this tells us that yes, most likely the cavernous sinus is involved because it impairs the drainage from this vein. So then this vein has a backward flow, or maybe find another route to go to the left facial vein here and here. And you can see if we were to scroll, it will end up in the external jugular vein. So this tells us that there is already impact mass occupying the left cavernous sinus. Okay. So another slightly down axial cut, we see the proptosis that has happened in the left orbit, okay, by the mass. But if you can see, this is actually another mucocele, probably a lot of thick secretions that has caused bowing into the extracorneal space on the left orbit here. Okay, as you can see here, the lamina propria is also eroded and bowed into the left orbital cavity, and most of the ethmoid sinus walls also are already eroded through. Okay, so again we see the large enhancing mass in the upper nasal ethmoid. Okay, and I want to put your attention to this. This is on my red arrow. This is the inferior orbital fissure, which has abnormal soft tissue enhancement if you compare to the other side, and also then it goes backward into the foramen rotundum here, and then into the cavernous sinus. So we know there is already prurinerous spread of this tumor to the nasopharynx and then further on to the middle left cranial fossa. If we just concentrate on the bone window, we see a lot of permeative kind of destruction of the basis sphenoid and also the greater wing of the sphenoid bone. Okay, usually yes, the sphenoid bone does have this medullary kind of appearance, but if you look carefully, the cortex is eroded through. And if you look on the coronal, it really shows that the cortical integrity is lost of the greater wing and mostly of the greater wing of the left sphenoid bone and also the pterygoid plates and the basis sphenoid. Okay, and also shown here. So we know that it has kind of gone through an important structure, which is the pterygopalatine fossa. On bone window, you cannot see the expected normal outline of the walls that makes up the pterygopalatine fossa. So this is MRI of the patient. This is T1 and T2 in coronal. So this mass is again seen in the left nasal cavity. Okay, this one shows the mucocele of the left maxillary sinus and also some complex mucocele in the left sphenoid sinus, which causes bulging into the anterior cranial fossa here. But the bone is still intact. Okay. So if we look at T2, just now we saw that there is involvement of the left medial cranial fossa. So the dura outlying the cavernous sinus here is thinned out as compared to this side, and it's also expanded. And it is slightly encasing the internal carotid artery as well. So here, the frontal bone is also eroded by the mucocele. Okay, and this view shows us nicely the extension into the extracorneal space of the left orbit. Here, the fat still, there is a small fat cleft in between the tumor and the muscle, the ocular muscles. Yeah. And again, this one shows the nasal cavity mass kind of going through into the left maxillary sinus. So this is a T2 and this is T1 fat set post-contrast. So in contrast, we can see nicely the invasion or obliteration or occupation of the left pterygopalatine fossa. We cannot see its outline, and also here, possibly I postulate that the pterygomaxillary fissure here is also widened, and part of the tumor has extended into the infratemporal fossa. So we see an abnormal enhancement of the left pterygoid muscle here. And there is a remnant here. If you see those two black dots, those are likely the branches of the left internal maxillary arteries that are kind of squashed in the pterygopalatine fossa here. And also the enhancement also extends into the nasopharynx, also to the right side, and involves the prevertebral space as well. Okay. And again, here we see the mucocele in the left maxillary sinus. But by this MRI, the collection has significantly regressed. So I don't really see the collection that we saw in the CT scan. This is MRI again in post-contrast, slightly left parasagittal plane, showing the tumor from the nasopharynx has extended into the clivus here. And this is actually thickening of the dura overlying the clivus. So it has caused some sort of a possibly reaction or infiltration to the dura there. And you see this one, the hard palate is intact as well as the soft palate. So on DWI and ADC, we see the mass, nasal cavity mass, is restricted in diffusion. So it tells us there is a higher cellularity of this lesion. So it shows up as hyperintense on DWI and hypointense on ADC. So that's the end of images. So in conclusion, there's a large enhancing left sinonasal mass with extension into the nasopharynx, base of skull, left cavernous sinus, pterygopalatine fossa and its related structures, and thickening of the dura. However, there is no intraperitoneal brain extension. What I mean is that there's no direct extension of the tumor or even any abnormal signals within the brain parenchyma, namely the in the left medial cranial fossa. Possible also that the epicenter is the left nasopharyngeal mass with forward extension to sinonasal and base of skull. And also in these images, we have regional lymphadenopathies, namely the retropharyngeal and the bilateral 2B nodes. And also there is mucocele of the ethmoid sinus causing bore into the extracorneal space of left orbit. And also just now, I forgot also mucocele of the left maxillary sinus, which has a collection into the left subcutaneous region. So based on imaging, the differentials are, it is a malignant feature. What malignant features we see on imaging are the osseous destruction. There is no necrosis, however, in the mass, because if we have necrosis, we should have kind of within the mass hyperintense signals on T2, and when we give contrast, it should not be enhancing. So for this, we don't have any necrosis. We see very kind of enhancement throughout the mass. And also there is no hemorrhage within the mass. There is perineural or dural spread, and there is restricted diffusion on DWI. So we know that based on these features, we're dealing with a malignant mass. There are very few pathognomonic imaging features, and virtually all sinonasal tumors require histopathology for specific diagnosis. But if we were to look at the differential based on imaging, if I would go for a squamous cell carcinoma, adenosarcoma, undifferentiated carcinoma, malignant lymphoma, and or extramedullary plasmacytoma. So if we look at squamous cell carcinoma, these are what can be expected in literature. So our patient has all of these except for intratumoral necrosis and hemorrhage in large size. So I think our tumor is large. However, there is no intratumoral necrosis or hemorrhage. However, at SCC, we don't have any distinguishable imaging features to differentiate with adenocarcinoma. If we look at sinonasal undifferentiated carcinoma, yes, also this patient has all of the imaging features except for distal metastasis and again central necrosis of the tumor. And if you look at sarcoma, it is reported that yes, it can fit in this patient. However, there is no hypoatosis on CT scan. We have more of erosion and bony destruction. Although these features are non-specific, and that is why I still put it in here. For adenocarcinoma, there is expected to have intralesional calcifications. However, this patient does not have. But then again, it is not pathognomonic, so it is fitting to be put in the imaging differential diagnosis. For malignant lymphoma, yes, it is also possible, except for if we look specifically at non-Hodgkin lymphoma, usually it crosses the sinus wall. So you have sinus wall remnant on both borders of the tumor, which we don't have in this patient. It is more of a destruction of the sinus wall. And again, there is no intratumoral necrosis. For extramedullary plasmacytoma, yes, it is. It does fit into this patient, but again, there's no necrosis and there is no vascular flow void because it tends to be a highly vascularized tumor. Although ours is enhancing, but there's no flow voids within the tumor to say that it is a hypervascular tumor. So just to reiterate, that differential based on imaging still stands at squamous cell carcinoma, adenocarcinoma, sarcoma, undifferentiated carcinoma, malignant lymphoma, and extramedullary plasmacytoma. But these are all malignant, and if we were to use staging for sinonasal, then it would be N2 because of the bilateral enhancing to be nose, stage 4B. And if we were to treat it as a nasopharyngeal tumor, then it will be stage 4A. Both are showing N2 staging. Okay. So this is just out of interest that post-treatment patient has the nasal cavity, the sinonasal mass that we saw earlier has significantly reduced. Okay, but the extension to the infratemporal fossa and the pterygoid palatal fossa area is still present. So there is still a bit of residual tumor, but most of the tumor in the sinonasal has significantly reduced in size. With that, I thank you.
Thank you, Dr. Aida, for that very comprehensive presentation. I think we also learned a thing or two about the differential diagnosis of tumors from the nasal cavity. Dr. Aida, please, can we ask some questions while Dr. Aziani is setting up? Okay, so I would like to welcome the next presenter. We took a biopsy, and the biopsy was sent for histopathological examination. And so Dr. Iziani will present the pathological findings from the histopathological examination. In the meantime, are there any questions? Maybe I can ask Dr. Aida, could you, for the benefit of the medical student, just tell a few features of malignancy for a lymph node? Because there were bilateral lymph nodes on the CT scan, but this was not palpable during clinical examination.
Hello, sorry. Hi. For malignancy of the lymph nodes, it has to, one of the the features are first enhancement. Okay, there is loss of fatty hilum. Number 2, if there's any central necrosis, okay, and if the border of the lymph node is ill-defined and you have abnormal enhancement, just on the soft tissue outside the tumor, outside the lymph node, and if the border of the node is irregular or lobulated, what else? And if it has lost its reniform shape, it's become a bit more rounded. So there are a lot. Yeah.
Okay, thank you, Dr. Aida. Okay, so without further ado, I see Dr. Aziani is ready. So please welcome Dr. Aziani to present the HPE findings.
Okay, Assalamualaikum and good morning to everybody. Okay, so I'm going to present on the HPE of this patient, Mrs. NZ, 62 years old female. Okay, on the 22nd of April 2024, we received specimen labeled F left nasal mass. Okay, so it is a whitish tissue measuring about 8 mm in the largest dimension, so it is entirely submitted. Okay, so this is the whole of the biopsy. Okay, so you see fragments of tissue. So we have areas infiltrated by malignant cells as highlighted in this yellow circle. Okay, and then we have areas of necrosis. Okay, so these malignant cells, they are arranged in nests, clusters, as well as some small sheets. Okay. Higher magnification, so fragments of tissue infiltrated by these malignant cells. Okay, they are forming small nests, some like trabeculae pattern, okay, some in sheets, and surrounding it are areas of necrosis and inflammatory cells infiltration. Okay, higher magnification, so these are the malignant cells. They exhibit enlarged pleomorphic and vesicular nucleus. So you can see here. What you see is mainly the nucleus, which is vesicular, and some contains nucleoli. Okay. And then there's moderate eosinophilic cytoplasm. Okay, again, this is also the malignant cells. Okay. So in this view, you can see there are some scattered mitosis here, as I highlighted in the yellow circle. Okay. And then there's some vague intercellular bridges. I don't know if you can appreciate. In between the cells, there are intercellular bridges, which shows that this has a squamous differentiation. Okay, so surrounding this malignant cluster, these are blood vessels. Okay, and then some inflammatory cells infiltration. Okay, there are no cytoplasmic keratinization or keratin pearl formation seen. Okay. Again, in other areas, there are some granulation tissue infiltrated by acute and chronic inflammatory cells, as well as areas of necrosis with abscess formation. Okay. Based on this morphology, we're thinking malignant cells with squamous differentiation. Okay. So we proceed with immunohistochemistry to prove that this is of squamous origin. So CK56 is positive, so you can see the brown staining of the tumor cells, and P63 is also diffusely positive. It stains the nucleus of the tumor cells. So these two stains, they are squamous markers. Okay. And Chi67 proliferative index is to show that this tumor is has high mitotic rate. Okay, so it's very proliferative, so it's high, about 90%. So we did other stains just to exclude other differentials. So in this case, CK7, okay, is negative. S100 and melan A is for melanoma, so negative. Synaptophysin and chromogranin is for neuroendocrine marker, which is negative as well. So our initial diagnosis is squamous cell carcinoma, body differentiated, as the biopsy was taken from the nasal cavity. Okay. And then additional test was requested by ENT team to do EBV in situ hybridization. Okay, so it turns out positive. So all this blue staining indicates the EBV infected cells. So these malignant cells, they are positive for EBV. So our final interpretation in view of the positive EBV, so the tumor likely represent non-keratinizing nasopharyngeal carcinoma differentiated subtype. Okay, so we advise for clinical correlation. Okay, so the current WHO 5th edition of head and neck tumor, if it's NPC, so they call it non-keratinizing squamous cell carcinoma, and they have dropped the differentiated and undifferentiated word, okay, because subclassification into differentiated and undifferentiated subtype is optional and not clinically or prognostically significant. So nasopharyngeal carcinoma, they are malignant mucosal epithelial neoplasm showing evidence of squamous differentiation. So it is divided into keratinizing and non-keratinizing, and also basaloid SCC. Okay. So the site is mainly at the lateral wall of the nasopharynx, especially the FOR. Okay. Non-keratinizing NPC is consistently associated with EBV. It is positive in practically all non-keratinizing NPC. Okay. So by histology, non-keratinizing NPC, we have infiltrative poorly differentiated carcinoma with limited evidence of squamous differentiation and variable density of lymphocytes and plasma cells. Whereas if it's keratinizing NPC, so we see the typical squamous cell carcinoma features with overt keratinization, which is not seen in this case. So immunohistochemistry, it will be positive for pan-cytokeratin marker, which prove that it is epithelial neoplasm, and for squamous marker, P63 and P40. Okay. So for this case, there are other possible differentials. Okay. The first one would be sinonasal lymphoepithelial carcinoma. Since the bulk of the tumor is in the nasal cavity, okay, this is also called primary sinonasal nasopharyngeal type undifferentiated carcinoma. It is a rare malignancy with undifferentiated appearing tumor arising in the sinonasal tract with associated prominent non-neoplastic lymphoplasmatic cells infiltrates. Histology is indistinguishable from those of undifferentiated NPC. Okay, so the site is mainly in the nasal cavity, paranasal sinus. So the sinonasal tract location defines lymphoepithelial carcinoma as a distinct entity from the nasopharyngeal carcinoma. Okay, so the main distinction from NPC relies on the location of the tumor. Okay. And more than 90% of cases are associated with EBV, especially in the endemic areas, in Asian, for example. Okay. Rare cases are EBV negative. Okay. For a lymphoepithelial carcinoma to be considered truly primary to sinonasal region, spread from nearby NPC must be excluded on clinical, radiological, and or pathological ground. Okay. So the immunohistochemistry would be similar. So they are also positive for pan-cytokeratin, CK56 and P63 and P40. These are the squamous marker. Okay. And negative for the other lymphoid, melanocytic, and neuroendocrine markers. So this is the closest possible differential diagnosis. The other diagnosis would be non-keratinizing SCC. Okay. So there is evidence in morphology and immunohistochemistry of squamous differentiation. Okay. Up to 58% are HPV associated. Only rarely it's EBV positive, but this is some remote study somewhere. Okay. Sinonasal undifferentiated carcinoma, so we have excluded this based on the immunohistochemistry. Okay. So this would show pan-cytokeratin positive. However, there will be negative for all the specific lineage such as squamous, melanocytic, or neuroendocrine marker. And there's no EBV association in sinonasal undifferentiated carcinoma. So the other differential, melanoma, so in this case, it doesn't show any melanocytic markers positivity. So we have excluded melanoma. And lymphoma, morphologically, it does not support because it doesn't show any lymphoid differentiation. Okay. Okay, that's all.
Okay, thank you, Dr. Aziani. Dr. Aziani, I think we have question from Prof. Ko.
Morning, thank you. Very extensive evaluation. Can I ask you, so your final conclusion or impressions is NPC?
Yes.
Okay.
However, I cannot differentiate between NPC and lymphoepithelial carcinoma based on the morphology.
We always say the histology is always the temple of truth. We have to go down to the basement to find the truth of the diagnosis. So your diagnosis, it will be still NPC lah. Can I say that?
The more common.
We based on your diagnosis as well to plan, if I'm not mistaken. Yeah, I think from because this is just for academic. Yeah, we always say common disease with uncommon presentation, still a common diagnosis than an uncommon disease. So I think in this case, clinicians felt that NPC is not that common in your presentation, and it was put lower down in the diagnosis. But and even on the CT, CT still felt that there's something else. Then now we have the histology diagnosis of, oh, okay, so now it's NPC. I think that's why it's CPC case. My question to you is, in the past, we do not really stain for EBV. This is something I'm telling you, from ENT when we studied a long time ago. And you mentioned that ENT requested for the staining. So is there something that trigger the diagnosis? And if there is no EBV staining, immunohistochemistry staining, will your diagnosis still NPC? Thank you.
If there's no EBV staining, probably my diagnosis would maintain at the first initial diagnosis, which is polydifferentiated SCC.
Okay, thank you, Dr. Aziani. I think I see some faces around here. So this case is a very surprising case. The Temple of Truth revealed something surprising because the patient presented like a carcinoma of the sinonasal cavity, but it turned out to be NPC. So this is because this is a Malay lady, no palpable neck nodes, nasal cavity mass, because NPC presents with nasopharyngeal mass, and even on these images, you can see that the mass is in the sinonasal cavity, pushing the maxilla with some extension into the pterygomaxillary fissure, going up into the brain, covering the sinus, and extending into the nasopharynx, not the other way around, not the nasopharynx going, jauh dia nak jalan kan. So I would like to ask, maybe I can ask Prof. Farah, or Prof. Aziz want to give comment?
I know you won't allow me to come again, but I don't care. It's good that you present this. We might go over time here, but I think it's interesting because I would agree with you for the second previous diagnosis, lymphoepithelial carcinoma and PC type. I think that is almost probably that's the best histological diagnosis. After that, we combine with radiology, then we can go to the sites. So nampak tak macam tu kan? Yes, we think of nasopharynx, but as we discussed just now, it doesn't go typical like NPC punya features. So we have that histology of lymphoepithelial EBV positive. In fact, this EBV positive can be in a few places. But we correlate with that, and I will ask next after this about the response of the treatment, because on the radiology tadi, Farah kata, kita nampak still there's some remnants dekat pterygoid region. So that will raise our suspicions whether is it true from the nasopharynx or actually it's not, it's in the sinonasal. So I will go for the first yang you cakap tadi, lymphoepithelial carcinoma EBV positive. You tak boleh halang saya.
Thank you, Prof. Aziz. Rampas balik mic. Okay, so Prof. Farah would like to tell why she asked for EBV staining.
So thank you so much. Basically, the first of all, I would like to clear the first why I would like to tell that why I request for MRI first. So because of the MRI, after discussion with the radiologist, and then there is a cavernous sinus involvement. When there is an intracranial and orbital involvement, we always request for MRI to see the extension of the disease. So that's why Dr. Aida already presented on the MRI. The reason why I request for EBV in situ hybrid-ish is because of the typical of SNUC does not go into basis phenoid, and there is a retropharyngeal nodes in the CT scan as well. So the typical features of SNUC, and then there is no necrosis. So it's not a typical of squamous cell carcinoma of the sinonasal. It's not a typical of squamous cell sinonasal undifferentiated carcinoma. So that's why we discuss, we request for EBV in situ hybridization. And we have a case before, and we reported it's a similar case. So that's why the treatment is going that way. Okay, so yes, there's also mass at nasopharynx, so that's why we just want to see whether it is from the nasopharynx or it's from the sinonasal. But after discussion with the radiologist, the epicenter of the mass is in the nasal cavity. Right. Okay.
So thank you, Prof. Farah. I think I'd like to reiterate why it's really important to differentiate NPC from sinonasal cavity tumor. Sinonasal cavity carcinomas or tumors are generally treated with surgery first and then followed by chemoradiation. But nasopharyngeal carcinoma is usually very chemo and chemo-responsive, radiosensitive. So with a diagnosis of NPC, say for Prof. Farah, the headache of doing surgery for this patient because it's inoperable, right, Prof. Razif? It's encased the carotid, it's involved the prevertebral muscle. Oh, okay. Okay. Okay, we will not go there. So without further ado, I would like to invite Dr. Faiza who is our oncologist, to present on the patient's treatment and the outcome. Thank you. This one. Okay.
A very good morning to everyone. So I have I think the easiest part after all the headaches with the diagnosis and all. So the patient came to me first at an MDT with all the imagings and the histology diagnosis and the EBER positivity revealed already lah. So basically, for these patients, the primary differential diagnosis when they come to us at the MDT was either it's primarily NPC versus sinonasal malignancy. So in sinonasal, we know there's many subtypes, but I just would like to talk about these two main differential, which is NPC and sinonasal in general. So all the data is basically based on the sinonasal SCC lah. Okay, the most common one. So I just next. Next macam. Scroll down. Okay. So NPC is divided, I think we've talked about this, so I just quickly run through this. This is the histology classification of NPC. It divided into keratinizing, non-keratinizing. I think Dr. Aziani has already mentioned that differentiated and undifferentiated is no longer applicable to the recent WHO classifications. And then we have basaloid tumor. Non-keratinizing WHO type 3 was the classification that is the most associated with EBV positive. Okay, now let's talk about EBV and NPC. EBV plays actually a pivotal role in NPC. It is not only as a causative agent, but it's also serve as a vital marker for prognosis and treatment management. So actually, I shared with you a systemic review here. Actually, talk about evidence-based recommendation for using the EBV titer for screening, staging, evaluation, and monitoring and response assessment, as well as surveillance. So you can have a look at this paper if you are interested further. So let's discuss how NPC spread within the body. So we know it spread through either local lymph node spread or hematogenous. Through local extensions, it actually can affect nearby structures. Anteriorly, there is a nasal cavity, orbit. Posteriorly, there's skull base, clivus, and the prevertebral muscle. Inferiorly, it can go down to oropharynx, and superiorly, it can go to the brain and the sinuses. So nodal spread in NPC is very common, typically involve bilateral lymph nodes, and it go down in orderly pattern. So the three primary routes of lymphatic drainage is retropharyngeal, jugulo-digastric level 2, as well as level 5, deep posterior cervical nodes, and then it goes to other cervical lymph nodes regions. So it also spread via bloodstream, especially with patients with advanced neck node metastasis. So it likes to go to bone, lungs, and liver. So this is illustrate the general treatment approach for NPC. So as mentioned before, unlike many other cancer where surgery is the primary, radiotherapy plays a central role in NPC. It is recommended to even the early stage T1 and 0 patient to have radiation therapy, and elective neck irradiation is mandatory because lymphatic spread is very high. For higher T and N stage disease, a combined approach recommended. So we combine with concurrent chemoradiations for these patients. And cases of metastatic usually predominantly treated with systemic chemotherapy. So the locations of nasopharynx poses challenge in treating due to its proximity to critical structure as illustrated in this image. So actually the nearby structure complicates its removal. Fortunately, it is radiosensitive and it can be cured by radiation therapy. So in terms of radiation therapy, actually the advancements in radiation has markedly improved patients' outcome. So the introduction, it used to be 2D radiation therapy, but now we have IMRT, which actually showed together with chemotherapy offer local control exceeding 90% at 2 years. And then it also can lower the side effect. Other techniques such as VMAT, volumetric modulated RT tomotherapy, and ion beam therapy also can be offered if the resource available. So in terms of target volume for NPC, actually radiotherapy must encompass this high risk area. So we have very specific area that we need to ensure covered during the radiation treatment. So including parapharyngeal space, pterygoid fossa, sphenoid sinus, nasal cavity, and also as inferior soft palates. And the lymph nodes that we must encompass in the radiation field include the RP node and the bilateral lymph nodes from level 1B through 5. So for induction chemotherapy in NPC, usually we use gemcitabine cisplatin for 3 to 4 cycles. Other regimens suggested by NCCN such as docetaxel, TPF regime, docetaxel, cisplatin, and 5FU are generally not practiced in our center. And then in the metastatic setting, you can combine doublet chemotherapy for patients, and the immunotherapy is also an option if resource is available. So moving on to sinonasal cancer. So it's a rare, as we know, it comprises 3% of head and neck cancer. So maxillary sinus is the most common location that it occurs at, followed by nasal cavity, and it is also linked to HPV and EBV. So let's talk about the how sinonasal cancer spread. It's commonly spread locally, often via local extension into the nearby sinuses and bony structures, because paranasal sinus and nasal cavity actually are connected by multiple openings and thin walls, making it easy for the tumor to spread locally to nearby areas. Lymph nodes metastasis, in contrast to NPC, is uncommon unless the tumor affects areas with extensive lymphatic drainage, such as nasopharynx or skin. So generally, lymph node involvement occurs in less than 50 to 20%. In cases of higher histology, this can raise to up to 30%. So it usually goes to the lung, but also occasionally goes to the bone. So the treatment for sinonasal tumor is customized by stage, but typically surgical resection is preferred, followed by adjuvant radiation therapy or chemoradiation, depending on the post-operative risk factor. For unresectable tumor, then the surgeon will pass the patient to us for radiations or concurrent chemoradiations. And then due to the rarity of lymph nodes metastasis, compared to NPC, elective nodal radiation is actually not mandatory. In cases for higher T stage and aggressive tumor histology, we normally would include as well. So the radiation therapy, usually we use 60 to 70 gray depending on the risk factor and the tumor residual. So I think the systemic therapy for sinonasal tumor actually lacks clear guidelines from the randomized trial, but we usually extrapolated from other non-NPC head and neck region chemotherapy. Cisplatin is usually given for concurrent treatment, and neoadjuvant chemotherapy is sometimes given for cytoreduction to facilitate surgery. And the other treatment option is palliative chemo, as mentioned there. So this is from NCCN, illustrating systemic treatment options for non-NPC head and neck cancer. So while there are many options, our common systemic treatment for sinonasal tumor in our center is weekly cisplatin. For unresectable tumor, induction chemotherapy options for that is commonly used is as mentioned there, cisplatin 5-FU or triplet region as TPF. I just would like to highlight here that induction chemotherapy is quite common in NPC, but in clinical practice for sinonasal tumor, we frequently use it because of sometimes patients presented with very symptomatic tumor burden. So we would like to reduce that immediately. Sometimes we give systemic chemo because sometimes when you introduce radiotherapy upfront, the side effect of radiotherapy sometimes is very intolerable to the patient. So that's why we go with neoadjuvant chemo. As well as actually it's a bridging treatment before patient can undergo radiation therapy because the treatment and waiting time also long, and then it also helps us modulate radiation therapy to critical organ. So despite its common use, it's actually there is no overall survival in the randomized trial. So just bear in mind. So this is systemic treatment. You can either use combination regimen, mainly combined with platinum agent, or you can use single agent therapy. So immunotherapy pembrolizumab also is an option, as well as targeted therapy with cetuximab. So as for NPC, we like to usually use a higher technique like IMRT for this tumor as well. So there are some key contrast between NPC and sinonasal tumor. So in terms of surgery, it's difficult for NPC and its only role is in biopsy and salvage treatment. Surgery is the preferred for sinonasal in contrast. Standard of care is radiations plus minus chemo for NPC and resection and adjuvant treatment for sinonasal. IMRT preferred for both. And EBV is the primary etiologic agent in the pathogenesis and prognostic for survival for NPC, whereas in sinonasal, maybe it has been linked, but the data is not so robust. And the lymph nodes involvement is rare in sinonasal and is very common in NPC. So back to our patients. So this patient, when she come to us, I think from the histology, mainly I would more incline to treat this patient as NPC. What is the difference between sinonasal and NPC is the induction part of chemotherapy, maybe slightly different regimen. The coverage of the tumor for radiation therapy for this particular patient, I think it would be almost the same. I think in reality, I would include all the major structure that I have shared with you just now, almost like NPC with all the lymph nodes up to level 5. So that's what I would do lah. Even though the patients come with sinonasal SCC, I think the tumor volume would be included similar as NPC. So this patient is planned for induction chemotherapy 3 to 4 cycles with IV gemcitabine 1 gram/milligram per meter squared and cisplatin and radical IMRT 70 gray. So she has received up to cycle 2, the induction chemotherapy. She tolerated it well, and she had a CT simulation done, so we can see the response lah. So So this is our CT simulation image, which was taken, I think, last week, showing the response of the tumor. Okay, sorry. And this is the photo of it. Yep, thank you.
Okay, thank you, Dr. Faiza, for presenting the case. So it looks like the patient had a good response to the radiation and chemo. So finally, I would like to invite Prof. Dayana, who is the lead of the CPC today. She's worked very hard to make sure the CPC goes smoothly and invite all the speakers. Prof. Farah will wrap up the session and speak a little bit to some discussion on this patient.
Thank you so much. As a last presenter, memang biasanya kosong So left with our postgraduate students. So it's okay, but I'd like to share with you. I'd like to thank you, Dr. Miss Nadira, for referring this case to me. Thank you so much. And then we have a discussion as well regarding how to manage this case. So this is the progress of the patient. Patient ongoing third cycle chemotherapy when we saw her. No epistaxis, no more nasal blockage, claim cheek swelling, but no more numbness and improving vision. So this is the scope view of the patient. If let's say you can see, this is the previous one. On the still photo is the previous one. Now this is the latest scope view. You can see that there is no more sinonasal mass there, or sinonasal, you can see up to the nasopharynx. So this is the inferior turbinate. So you can see this is after we clean the nose, because there's lots of crusting. Even the nasopharynx is also clear. Right, so this is a good response with chemo and also chemotherapy for this patient. So, so the final diagnosis that we want to share is a primary sinonasal type nasopharyngeal carcinoma. So this is for basically this I prepare for medical students. So okay, because I would like to wrap up. So let's see what is. Let's go to the algorithm. Okay. So, all right. So, for the sake of master student as well, this algorithm for management of unilateral nasal mass is very important. Okay. So this is from the book. You can see. Sorry. There's a pointer. Okay, so this is from the book basically, and also from the journal, saying that you have to do the, if let's say you have a unilateral nasal mass, do a diagnostic nasal endoscopy. Usually, if let's say there is a center with a CT scan, you can do an order CT scan. Like during I was trained in Chulalongkorn, the CT scan is in the clinic, so you can do a CT scan directly and also do a biopsy. But if let's say we, if not feasible, we can do a biopsy. But there is a few criteria for doing biopsy before we order for CT scan, and also after that we order imaging. So for unilateral nasal mass, this is our current practice, right? So if let's say you scope the patient, it is lateral to middle turbinate and non-vascular appearance, you can take a biopsy. But if let's say it's a medial to middle turbinate with vascular appearance, please do imaging first, okay? It can be from the intracranial, it can be vascular lesion, right? So biopsy and so what imaging that we request first for sinonasal? Usually it is a CT paranasal sinus, and depending on the extension. If let's say there is extension to the neck, we request neck, skull base, brain, and also orbit. It depends on the extension of the disease. And if let's say there is an extension to that particular region, then we request for MRI, okay? But for tumor, I would like you to please request for IGS protocol. If let's say you want to do surgery, we no need to do another scans for image guided system protocol, okay? So if let's say it's imaging is intracranial, please discuss this case with the neurosurgeons and see what is the differential diagnosis. So this is the differential diagnosis that have been mentioned before. So what is the diagnostic dilemma? Because of the biopsy come back as MPC, but the sinonasal, the primary is in the nasal cavity. So I skip this one. Okay, I would like to show this how with the points towards and points against for histological diagnosis, right? For postgraduate student, if in exam you say the first diagnosis is primary sinonasal nasopharyngeal type carcinoma, meaning that is you get already seorang bocor lah, because it's very rare. So the first diagnosis clinical diagnosis you need to give is a squamous cell carcinoma, SNUC, because initially we don't give you any histological report at that moment, okay? So this is why the clinical symptoms is the same, but the features of the histopathological examination, the epicenter of the mass is different. So you can see nasopharyngeal carcinoma, why it points again is because of the epicenter is in the nasal cavity. So that's why the diagnosis come back. We agree of primary sinonasal nasopharyngeal type carcinoma, which is the other name that we cannot differentiate is a sinonasal lymphoepithelial carcinoma. So it is a very rare tumor, right? It's usually lumped together with SNUC. And the histological characteristics, some histology reported as undifferentiated, poor differentiated, but must be in nasal origin and is very aggressive, right? And then in this tumor, it's very aggressive, it involves the basis sphenoid, and also it's going to the nasopharynx, and the patient also has a retropharyngeal nodes involvement. So this is Zhang et al. They describe the distinct histological variation is similar to NPC and is most often are EBV positive. And bear in mind this kind of tumor respond well to CCRT, combined chemotherapy and radiotherapy, which is similar regime to nasopharyngeal carcinoma. So previously reported there is a possible role of EBV in development of SNUC, but the study shows that mostly in Asia, right, all of the cases of SNUC that they collected, there's no EBV associated. Okay, so this is the Zhang et al. Also collected. He differentiated between the sinonasal nasopharyngeal type carcinoma and also the SNUC. So this is the table showing that the primary sinonasal type undifferentiated carcinoma. You can see here that the radiation therapy was used and surgical resection was done and chemotherapy was given, but there will be a different outcome. However, in this paper, they didn't mention what is the extent, the staging of the tumor. So that's why you can see here the involvement of the bone, patient already passed away. So I think that's there is a heterogeneous data there. So PS and PC also we can say is a sinonasal lymphoepithelial carcinoma because in WHO classification, there's no PS and PC. There's only sinonasal lymphoepithelial carcinoma. So, but since the histological is not is difficult to, because it's almost the same, so we would like to diagnose this, give a diagnosis of this patient as PS and PC. So, previous literature until 2003, only 40 cases has been reported, and most of cases usually present with locally aggressive disease without regional lymph nodes metastasis. Okay, so the difference between nasopharyngeal carcinoma and this case is because of in what about the almost all cases involve EBV in NPC, but in PSNPC it can only 90%. It can go up to 90% association of EBV, and it must. This is the immunohistochemical analysis of this case basically. Okay, but the most important thing is the tumor location, all right? So you have to diagnose the patient based on tumor location. So due to limited number of cases, there's no standard protocol for treatment, typically responds well to radiation therapy with or without surgery or chemotherapy. So this is our paper. We have a case before. In 2017, I think, EBV positive, primary sinonasal nasopharyngeal type carcinoma. So this is a second case in our series, basically. So as a conclusion, multidisciplinary team discussion is important in managing this type of case due to dilemma of the diagnosis, extensiveness of the disease, rarity of the case, and no standard protocol treatment for PSNPC or lymphoepithelial carcinoma of the paranasal sinus. Okay, therefore, I think I end my presentation. Thank you.
Okay, thank you very much, Prof. Farah. So are there any questions from the audience? We're very sorry for going over time, but I think because case sangat-sangat, so there are a lot of questions and discussions. Okay, so if there are no more questions, I would like to thank all the presenters, Prof. Farah, Dr. Iliyas, Dr. Aida, Dr. Aziani, and Dr. Faiza for coming here to present this very interesting case today. Okay, thank you.